Okay, let's dive right into one of the most critical emergencies we face, acute hypoxemic respiratory failure. This is one of those situations where every single second counts, so we're going to break down the essential steps for diagnosis and that crucial initial management. So picture this. You walk into a room, your patient is gasping for air, their sats are dropping on the monitor. What's going through your head? Your ability to rapidly and accurately assess what's happening can literally change the entire course for this patient. Let's get it right from the start. First things first, let's make sure we're all on the same page. Acute respiratory failure is, simply put, when the lungs just can't keep up. They're failing at their two main jobs, getting oxygen in and getting CO2 out. And it's so severe that vital organs are starting to feel the squeeze. Those numbers you see there, a PaO2 less than 60 or a PCO2 over 50, those are our classic alarm bells on an arterial blood gas. All right, here's our game plan. We'll start with how to spot respiratory failure in the first place. Then we'll get into the big one, ARDS, and how we even define it has been changing. From there, we'll talk about our first moves, what kind of respiratory support to use, and a cool technique called awake proning. And we'll wrap it all up with the key take-home points. So you can't manage what you don't recognize, right? Let's talk about what this actually looks like at the bedside. What are those signs that should make your spidey senses tingle? Now here's where it gets tricky. Look at these lists. You see a lot of overlap, right? A patient who's confused, agitated, with a wacky heart rate. I mean, that could be a dozen different things in a sick patient. It's really easy to mistake these signs for something else, which is why you have to be vigilant. And that leads to probably the most important point in this section. You cannot, and I mean cannot, rely on the clinical picture alone. Your eyes and ears are great for raising suspicion, but they can fool you. The bottom line? If you're even thinking about respiratory failure, an ABG is not optional. It's absolutely essential to get that objective data. Okay, so we've identified acute respiratory failure. Now we have to narrow it down. And one of the most severe, most challenging forms is the acute respiratory distress syndrome, or ARDS. The key thing to remember about ARDS is that it isn't one specific disease. It's a syndrome. Kind of like a final common pathway for a bunch of different insults, like sepsis, pneumonia, or major trauma. What happens is a massive inflammatory bomb goes off in the lungs. The capillaries get super leaky, fluid floods the air sacs, and the lungs become stiff, waterlogged, and basically useless for gas exchange. And this image shows it perfectly. Some kind of trigger kicks off the injury, you get all that edema, and on an X-ray, you see these classic white-out lungs. This is where that concept of the baby lung comes from. It's a fantastic mental model. It's not that the lung shrinks, but that you're left with only a small, healthy-ish portion that's actually doing all the work. Now, you'd think the definition for something so serious would be set in stone, right? Wrong. How we define ARDS has been a moving target for over 50 years, constantly evolving so we can get better at recognizing it earlier. You can really see the journey here. It all started back in 1967. We had a few versions, but the Berlin definition in 2012 was a huge leap because it tied the definition to how sick the patient was, to mortality. And now, the very latest definitions are even more practical, making it possible to diagnose ARDS in more patients and in more places around the world. This table really highlights the game changers, the biggest shifts: imaging and oxygenation. We can now use ultrasound at the bedside to help diagnose, which is huge. But even more importantly, the new global definition lets us use pulse oximetry, SpO2, and includes patients on high-flow nasal cannula. This is a massive deal for catching ARDS earlier. The Berlin definition was such a step forward because it gave us a prognostic tool. It wasn't just about naming the syndrome, it was about understanding its severity. By splitting ARDS into mild, moderate, and severe based on the P to F ratio, it gave us a very real, very sobering look at the patient's risk of dying. So, the real story of the new global definition is this: inclusivity. It's about expanding our net. By bringing patients on high flow into the fold and by allowing SO2-based numbers, we can now diagnose ARDS in so many more patients, and crucially, so much earlier in their course. And that means we can start life-saving treatments sooner. All right, we've diagnosed it. Now the big question, what are we going to do about it? Let's get into the initial management and those critical first moves in providing respiratory support. I want you to think about this like an escalation ladder. For pretty much any patient with pure hypoxemic respiratory failure, we're going to start with high-flow nasal cannula. If they're not getting better, or if they're also retaining a lot of CO2, maybe we try a mask or NIV. But if they keep getting worse, or they're just too sick from the get-go, We don't hesitate, we move straight to intubation. This quote really drives home the point. High flow isn't just a comfy way to give oxygen. It's clinically superior. It gives you a little bit of PEEP, it washes out dead space, and it reliably delivers that high FiO2. For a lot of patients, this is the intervention that keeps them off the ventilator. So we've talked about how we deliver oxygen, but there's another surprisingly simple yet powerful physical maneuver we can use: awake prone positioning. Now, this is super important. Awake proning is not for everybody. Patient selection is everything. The ideal candidate is someone who's cooperative, has mild to moderate hypoxemia, and isn't totally exhausted yet. But you absolutely have to avoid it in unstable patients or, critically, if it's going to delay an intubation that they clearly need. And here's why it works. It's simple physiology. By flipping the patient onto their stomach, you help recruit those dorsal dependent parts of the lung, which improves ventilation perfusion matching and boosts their oxygenation. It's a low-tech, high-impact therapy that can genuinely help the right patient avoid intubation. Okay, we have covered a ton of ground. Let's boil it all down. What are the key things you need to walk away with? The stuff you can use on your very next shift. All right, here are your take-home messages. Number 1, ARDS definitions have expanded so we can diagnose it earlier and in more patients. Number 2, your go-to starting point for hypoxemic respiratory failure should be high-flow nasal cannula. 3, don't forget about awake proning in the right patient. And finally, if you do have to intubate, you must use a lung protective strategy. That means low tidal volumes. And that leaves us with this final, really interesting question to think about. As our definitions get broader and more sensitive, are we running the risk of overdiagnosing ARDS? Or are we finally catching these patients early enough to make a real difference? It's that classic balancing act between sensitivity and specificity, and it's something we're constantly trying to perfect.